about recent developments in autosomal dominant polycystic kidney disease, and I'll refer to that as ADPKD during this talk. So this is a genetically inherited disorder that causes a decline in renal function. It's characterized by very prominent expanding renal cysts that are usually present bilaterally. And you can also have extra renal manifestations of hepatic cysts, pancreatic cysts, and vascular changes. And so this will show you that the kidneys actually, over a lifetime, they become very large and are filled with cysts. And so that characterizes this disease. It's the most common form of inherited cystic disease of the kidneys and the most common genetic cause of chronic kidney disease, with a prevalence of about 1 to 400 to 1 to 1,000, affecting up to 600,000 Americans. It's a more progressive disease in men than in women, with a male-female ratio of 1.3 to 1. And annually, 5% of dialysis initiations in the U.S. are due to ADPKD. And the disease is caused by mutations in the polycystin 1 and polycystin 2 genes. Polycystin 1 is a membrane protein located in the renal tubular epithelium, hepatic bile ducts, and pancreatic ducts, and it's involved in some cell-cell signaling and cell matrix signaling. So it involves in signaling in between cells and in the cell matrix. And it is involved in intracellular signaling pathways that are involved in cellular proliferation and in survival. And polycystin 2 is a membrane protein located in the distal tubule, collecting duct, and thick ascending limb. And it's involved in cellular calcium signaling. And the polycystin 1 and polycystin 2 proteins actually work together. They're located right next to each other, and they work together. And polycystin 2 can function as a non-selective calcium ion channel. And there are two types of ADPKD based on mutations in these two different proteins. So type 1 involves a mutation of the polycystin 1 gene, which is on chromosome 16. And it codes for polycystin 1, and that accounts for 85% of cases of ADPKD. It's the more severe form of the disease compared to type 2, and that is because more cysts develop in the kidney in type 1 than in type 2. And you can have phenotypic variability with incomplete penetrance or mosaicism, so that family members with the same mutation may present with very different, degrees of the disease. Type 2 is caused by a mutation in the polycystin 2 gene located on chromosome 4, and that codes for polycystin 2, and this accounts for 15% of the cases of ADPKD. And it's a milder form of disease. There are fewer complications with hypertension, UTI, or hematuria, and PKD survival is much longer compared to PKD1. PKD2 survival is longer compared to PKD1. And so this shows you an idea of the progression of the disease. So essentially the kidney function remains stable over decades, while the cysts in the kidney are enlarging over this period of time, and that at a certain point the renal function begins to decline rather precipitously. And then in the PKD1, that begins at about 50 years of age, and in PKD2 that begins around 70 years of age. So you can see that there's a big difference between the way that PKD1 and PKD2 progresses. There's no real evidence of glomerular sclerosis, and the proteinuria should be about 1 gram per day. So if you have proteinuria above that, you may have a completely separate process going on. And when the GFR starts to decline, the average yearly decrease is 4.5 to 5.9, which is a very rapid decrease in kidney function. And so this shows you here in the early stage of the disease. This is a T1 weighted image with the renal parenchyma is bright. So this, you see more normal renal parenchyma here with some cysts, and as it progresses you see less and less working renal parenchyma and more cysts. But in each one of these patients the GFR is normal. Okay, so this is progressing along a line where you have a normal renal function, more and more cysts, and then you have hyperfiltration and kind of a compensatory hyperfiltration in the remaining renal parenchyma that keeps the GFR normal, then it falls off the cliff. So it's a genetic mutation that's autosomal dominant. Each child of an effective parent has a 50-50 chance of inheriting the mutated gene. You can get a spontaneous mutation in 5% of cases, and there are hundreds of mutations of these two genes that account for the ADPKD, and the current testing can identify about 63%. So essentially it's a two-hit model where you have one normal allele and then you have a mutated allele, and you need a hit to that normal allele to have this process begin in the kidney. So this will kind of show you, here's a normal tubule, and then here you can see that you can have the cyst develop anywhere along the tubule, okay? And what happens is, within this kidney, you begin having an abnormal proliferation in these affected cells, and they begin proliferating tremendously. You get a thickened basement membrane and a tremendous amount of fibrosis building up. And that kind of, you have an outpouching that gets bigger and bigger and bigger. And then when it gets about 2 millimeters, it completely pinches off from the tubule, and it's an autonomous fluid secreting cyst separate from the tubule. And these are some pathways involved. This is adenyl cyclase that forms CAMP. So when this is stimulated, you form CAMP, and that causes stimulation of the chloride-based secretion into the lumen of the cyst. But it also causes proliferation of the cell through this pathway, okay? So, and then you also have kind of a growth factor mediated process where growth factor will bind to receptors and then stimulate cell proliferation. And so looking at this, you can see where here, if you have vasopressin, can stimulate the production of CAMP. So if you have a vasopressin receptor antagonist, that could decrease the production of the CAMP here, okay? Somatostatin also can limit the production of CAMP here at this level. And then you have the mTOR process that is involved in the protein translation. If you block the mTOR, that could possibly cause a decrease in the proliferation involved, okay? So these are some targets of therapy that have been identified, and we'll talk about the recent developments in that. So cyst formation comes from multiple dysregulated processes. You have the CAMP stimulating the cell proliferation and the chloride-driven fluid secretion. We talked about that. You have upregulated cell proliferation, activation of transcription factors that involve the mTOR complex. So the course of the disease, 35 to 45% will end up on end-stage renal disease by the age of 60, okay? Now there are some risk factors for who will progress more rapidly than others, and that is some people who are young at the age of diagnosis, less than 30 years old. Males progress more rapidly, a PKD1 mutation as opposed to the PKD2. And then if somebody has episodes of gross hematuria, that's a bad sign, and it could mean that they will progress quicker. High blood pressure has been shown. People with hypertension have a larger total kidney volume compared to people who are normotensive. So hypertension is a risk factor for larger kidneys in progression of disease. Proteinuria also, and then increased renal size and the rate of cyst growth. Each person's each person has a cyst that will grow at a set rate. There's no particular rate, you know, that everyone's cyst will grow. Each person's cyst will grow at a different rate, so someone may have cysts that grow much faster than another person, and that could be a factor. And then certain genetic mutations will increase the risk of progression to end-stage renal disease. The characteristics of this disease are cystic enlargement in both kidneys, hypertension, hematuria. They can get polyuria with the concentrating defect where the tubules just aren't able to concentrate the urine. They can get flank and abdominal pain from the size of the kidneys or infection. They can get recurrent UTIs, kidney stones, and also an elevated erythropoietin level. So the extrarenal manifestations you can have includes liver cysts, pancreatic cyst, thyroid cyst, subarachnoid, and seminal vesicle, and this is showing someone with polycystic liver disease with just a tremendous amount of cysts in the liver, okay? There's a vascular phenotype that will cause a person to get intracranial aneurysms. They may have early onset hypertension, mitral valve prolapse, aortic root dilatation, or abnormalities in biventricular function. And also they tend to get inguinal hernias more than the normal population. So looking at the intracranial aneurysm, you see one right there. So the polycystin is expressed in the vascular smooth muscle cells, so they can get intracranial aneurysms. Those occur in 6% of patients without a family history, and in 16% of patients with a family history of aneurysms. Okay, so the family history is a very important factor in trying to see who actually is going to get these aneurysms. So you want to screen ADPKD patients who have a family history of aneurysm or subarachnoid hemorrhage. If they're preparing for major elective surgery, you may want to go ahead and see if they have an intracranial aneurysm so that nothing bad happens during the surgery. People who are in high-risk occupations like an airline pilot or something, you don't want, you know, an aneurysm to rupture while they're flying, so you go ahead and screen them. And if a patient just has tremendous anxiety related to whether or not they have an aneurysm, you can go ahead and screen them for that. And there's usually conservative management for an aneurysm less than 7 millimeters. So kidney stones are fairly common. They can occur in 20% of ADPKD patients. Usually it's uric acid or calcium oxalate and associated with an increased total kidney volume. And CT stone protocol is a diagnostic method, and ultrasound really won't tell you very much because those kidneys are usually very large. And the risk factors for this are low urine volume, hypercalciuria, and hypocitraturia. And so hematuria can occur in 35 to 50% of patients. The precipitating event can be a UTI or strenuous activity, or maybe they have a stone. And gross hematuria is associated with a more rapid progression of kidney disease. And it can be caused by a rupture of the cyst into the collecting system. So you can rupture into the collecting system, which would give you hematuria, but the cyst can also rupture without draining into the collecting system. So you would have pain, but no hematuria at that point. And the treatment is bed rest and hydration. So when people have a positive family history, then there is an ultrasound criteria developed to screen them for ADPKD. And you know, if they have parents who are involved or have, you know, are showing the disease, they have a 50% chance of having the disease. Ultrasound imaging is the imaging mode of choice. It's non-invasive and safe, but it can be less reliable in younger patients because the cysts are much smaller in the younger patients, so you can miss a cyst there. Genetic testing may be an option when a definitive diagnosis is required, and this is rather controversial, but screening in asymptomatic people less than 18 years of age is not recommended because a positive diagnosis in young individuals could jeopardize insurability, although there have been reforms to insurance laws recently. It can jeopardize their career or jeopardize, you know, their emotional standing. And if a parent decides to screen for the child, you're kind of taking away that child's decision-making capacity on whether or not they want to screen for that disease. So in general, it's not recommended in children 18 years or younger. And that has been because there's no proven therapy to halt progression of the disease, and we'll talk about that a little later. We're going to talk about that. So adults, you want to screen potential living-related kidney donors of a person who is ADPKD, they're approaching end stage, they're looking for kidney donors, then you will want to screen that kidney donor to make sure that they don't have the disease. And prior to testing, you want to let them speak to experienced genetic counselors so that they understand all the ramifications of the testing and also receiving a diagnosis. And ultrasound, really they should get an ultrasound between the age of 20 and 30, 30 at the latest. So here's the modified criteria for ultrasound diagnosis. So you can see essentially if they're age 15 to 39 with the family history and they have 3 or more cysts unilaterally or bilaterally, then that has a positive predictive value of 100%. 40 to 59, 2 or more cysts in each kidney is required to make the diagnosis. 60 years or older, then 4 or more cysts in each kidney is required. And to exclude the diagnosis in this person with a family history, if they're 15 to 39, if they have 1 or more cysts, then you really can't. 40 to 59, 2 or more cysts, and more than 60 years old, 4 or more cysts in each kidney. So they'll have to have less than that to be excluded. And these are the positive and negative predictive value. So genetic testing is usually done in the clinic, and definitive mutations can be determined in 41 to 63% of the cases, and definitive and likely disease-associated mutations are in 78 to 89%. It's labor-intensive and expensive, and usually it's performed on young persons. If it's indeterminate on ultrasound whether or not they have ADPKD and they want to be a kidney donor, then you may consider doing genetic testing to find out for sure. So if a person has no family history of ADPKD, then there's no definitive number of cysts for diagnosis. ADPKD is strongly suggested if they have 5 to 10 cysts present bilaterally with large kidneys. And evaluation of a parent, you can go into their family history, see if someone else has had kidney disease, see if someone else has large kidneys. But it's important that if you have someone without a family history who shows up with a lot of renal cysts, you want to see if they maybe have tuberous sclerosis or von Hippel-Lindau. Okay, you want to try to make sure they don't have that, because especially with von Hippel-Lindau, they'll be predisposed for certain malignancies. You don't want to miss that. So this is showing some other cystic diseases. You can have cysts, simple cysts with just a few cysts that are diffuse, can occur at all ages. You can have acquired cystic disease. If someone has been on dialysis for a while, they can develop a number of cysts in their kidneys, but usually those kidneys are small. They're not large like the ADPKD kidneys. Tuberous sclerosis can have some. Also, you have autosomal recessive polycystic kidney disease. It has a tremendous number of cysts, and also some hereditary cystic diseases with interstitial nephritis. So one important way to measure progression of disease in ADPKD is looking at total kidney volume. And that's an MRI quantification of the size of the kidney. And a total kidney volume is both kidneys, okay? And there have been studies validating the use of total kidney volume as an indicator of disease progression. And it's often used as a primary endpoint, but there's not a clear correlation of total kidney volume with glomerular function, which kind of is one of the main correlations you would want to make in a primary endpoint of a study, and that's caused some problems in some recent studies. So this is the CRIS study, and this study quantified the rate of change in total kidney volume and compared that to the rate of change of the cysts in the kidney, the cysts alone. And what they determined was that as a kidney increased in size over 3 years, almost the entire increase was due to the cyst. So the increase in the size of the cyst is causing the total kidney volume to increase, okay? And they also made kind of a correlation to GFR in this study, and what they found was if the people had a baseline kidney volume, baseline total kidney volume of more than 1,500 milliliters, that was associated with a declining GFR by 4.33 milliliters per minute per year. So the bigger the kidney, the greater the decrease in the GFR. Okay, so they made that correlation. And then this is showing you total kidney volume here and age, and I think this is a great picture to show you. These are this is each person's development over those 3 years. And you can see some people's cysts increase at a much slower rate than other people. And this is showing, the blue is PKD2, which is the milder form of disease. The red is PKD1. And you can see that some people, even if they're young, their cysts really increase extremely rapidly. The size of their cysts increase rapidly, and then others don't increase that rapidly. So that's a great picture to show you the variability in the development of this disease. So they did a follow-on study, 21 participants, and they enrolled them in a 5-year study, and a lot of the people in the first study just re-enrolled in this observational study. So all of these patients had a GFR more than 60, and the total kidney volume was referenced to height, okay, to account for body habitus. So it's the height-adjusted total kidney volume, and essentially they found a couple of factors that would predict the development of CKD3 within 8 years. So here's another correlation of total kidney volume and that increase with GFR, okay? So if you have a baseline total kidney volume of 600 cc's per meter, then you have a likelihood of developing CKD3 in 8 years. If you have a baseline, if you have an increase of 100 over your baseline within that period, then you also are at risk of progressing to CKD3 within 8 years. So here's another correlation between total kidney volume and GFR, and they found that the total kidney volume was a better indicator over this period of time than age, baseline creatinine, urine albumin excretion, and BUN. Okay, so there's some connection there between total kidney volume and GFR, and it intuitively makes a lot of sense that you have these giant cysts developing. So they're proposing that the height-adjusted total kidney volume can be used as a prognostic indicator. Okay, you can tell if someone's going to get worse or not. So there's no proven therapy to prevent or delay the loss of renal function. There are general preventive strategies: blood pressure control, low-salt diet, statins. Amiloride has been postulated to decrease the sodium entry into the cyst by blocking the ENaC channel. Caffeine restriction theoretically could have a beneficial effect because it'll decrease CAMP levels. And you want to treat the symptoms like pain, hematuria, infection, and protein restriction has been proposed, but there's no clear evidence of a benefit of it. So the other treatment, if you have infected cysts or UTIs, and there's a little emphysematous areas here, UTIs occur in the 30 to 50% of patients. Usually it's gram-negative bacteria, and it requires antibiotics that will penetrate into those cysts, okay, like Cipro, Bactrim, or clindamycin. And you would consider cyst drainage if it will relieve pain. It can sometimes effectively relieve pain, but there's no evidence that it improves renal function or delays the rate of disease progression. Statins, actually, there's a recent study that showed that statins slow the rate of cyst growth. So statins will improve blood flow and endothelial function in ADPKD patients, okay? So there's a randomized controlled trial of 110 pediatric patients age 8 to 22 with normal renal function, and they randomized them to receive either pravastatin or a placebo for 3 years. And each patient in the study, even if they were normotensive, were on lisinopril unless their blood pressure was in less than the goal for the less than 25th percentile, okay? So there's a goal for, this would be, the blood pressure in this percentile would be too low to start them on ACE, in other words. So the primary endpoint was greater than or equal to 20% change in total kidney volume, 20% change in left ventricular mass index, or urine albumin excretion. So fewer subjects taking the pravastatin reached the primary endpoints. So it was statistically significant. Fewer had a 20% increase in the total kidney volume, and the percent change in total kidney volume was 23% in the pravastatin arm, 31% in the placebo arm, but there was no correlation between total kidney volume and creatinine clearance or urine albumin excretion. So you have the kidney volume marker improve on this therapy, but there's not really showing you a correlation with renal function, okay? So you don't have an improved renal function. And there weren't that many side effects either. So this is really interesting, you know. This statin seems to slow the growth of these cysts. So you want to also treat the hypertension. So the rate of progression of renal failure with uncontrolled hypertension is pretty high. So you need to control that. So, and blood pressure in ADPKD is likely mediated by the renin-angiotensin-aldosterone axis. So you have ADPKD patients with hypertension have a higher cyst volume than those without hypertension. And also the cysts, the thinking is this, the growth of the cyst within the kidney actually attenuates the blood vessels within the kidney, and it leads to areas of ischemia and decreased blood supply, and that will cause an increased secretion of renin and angiotensin II and aldosterone. And so studies have shown that the plasma renin activity is actually higher in the ADPKD patients with hypertension than without. And so also proteinuria is associated with the loss of renal function, and aldosterone and vasopressin may be elevated to cause volume expansion, and the hypertension associated with left ventricular hypertrophy occurs in 50% of ADPKD patients 40 years of age or older. So left ventricular hypertrophy is also present, and so treating the hypertension will reduce the left ventricular hypertrophy. So really the ACE inhibitor is the drug of choice to treat, is the first line drug to treat hypertension and ADPKD. There have been studies, ACE inhibitor versus calcium channel blocker, where you have ACE inhibitors more effective in reducing left ventricular hypertrophy. And then candesartan showed a benefit versus amlodipine here. And then diuretic should be a second line behind an ACE inhibitor and a calcium channel blocker, okay? And then a beta blocker can be like also a second or third line drug, but the ACE inhibitor is number 1 and number 2 is calcium channel blocker. So blood pressure goal, this is kind of an area of controversy also. KDIGO recommends a blood pressure less than 130/80 in proteinuric CKD, okay? JNC 8 recommends blood pressure goal of less than 140/90 in CKD, even if they have proteinuria. But there is a study showing that a more rigorous target of less than 120/80 could be beneficial in ADPKD patients, okay? So they chose 2 levels of blood pressure, and with the lower level, there was a benefit with regard to left ventricular hypertrophy, okay? So it's reasonable to consider a lower blood pressure goal, and they actually just came out a couple of months ago with the results of the HALT PKD trial that looked into exactly that. Okay, these are 2 studies published in the New England Journal of Medicine to evaluate a standard blood pressure, which to them is 130/80, 120 to 130 over 70 to 80. That's the standard blood pressure group, whereas they have a low blood pressure or more rigorously controlled blood pressure of 95 to 110. With a diastolic of 60 to 75, okay? So, so you're evaluating standard versus lower blood pressure control, and also in a 2x2 factorial design, they are looking at whether monotherapy with an ACE is the equivalent of an ACE and an ARB, dual renin-angiotensin blockade, okay? And it's a 5 to 8 year follow-up. So essentially, in study A is the study where they looked at both of these things, and with the primary endpoint being % change in total kidney volume, okay? These patients were younger, had less advanced disease, and a higher GFR, okay? In study B, they were looking mainly at the benefit of the ACE and the ARB dual blockade versus monotherapy, okay? Those were older patients, had a decrease, less good renal function, and their primary input was time to death or end-stage renal disease, or 50% reduction in the GFR. Okay, here's their blood pressure goal. So they did not have the rigorous blood pressure category. Okay, they didn't have the low blood pressure category. They had one blood pressure category in the second study. Okay, so here's study A. This is study A. 558 people randomized. So the people in the standard, it was half and half. The people in the standard, they divided those into monotherapy with lisinopril or dual therapy with lisinopril and an ARB. And they did the same thing for the low blood pressure arm. And this says you're looking at total kidney volume here. This is standard blood pressure. So the kidney volume was higher, and it's statistically significant rate. The kidney volume is higher in the standard blood pressure compared to the low blood pressure group. The change in the GFR in these two groups was essentially the same. Excuse me. They did a subgroup analysis that showed that this benefit on total kidney volume was especially true on kind of the around 30 years of age, males, and with a baseline kidney volume that was above the median. So the kidney size is a little on the large size, okay? They're not the smaller kidneys, and the baseline kidney volume is in above the 75th percentile. Okay, those are the people who really benefited by this lower blood pressure group, okay? So here's a blood pressure target for people with ADPKD. If they're men, you know, with preserved renal function and kind of kidneys on the higher side, okay? Then total kidney, this is looking at the, just looking at it from the aspect of dual therapy versus monotherapy. Is there a benefit on total kidney volume to have the dual therapy versus monotherapy? And there's not. There's not a statistically significant benefit here. And also not in the GFR, okay? There's not a benefit in terms of GFR for taking the dual blockade of the renin-angiotensin system. So the annual percent increase in total kidney volume was significantly lower in the low blood pressure group than in the standard group. And so the low blood pressure group had a 14.2% slower annual increase in total kidney volume. But there was no difference or change in the rate of GFR. So they didn't benefit in terms of GFR, but the kidneys were smaller, okay? Now they did have increased episodes of dizziness in the low blood pressure group. And so dizziness was in 80% of low blood pressure, 69% of the normal, the standard blood pressure group. So they both had some dizziness there. And the subgroup analysis showed that the lower blood pressure control benefits those groups we talked about. Okay. And then the dual RAS blockade did not really show a benefit. So looking at study B, this has 486 patients. One arm was in the dual blockade, the other arm was in the monotherapy. So they looked and they had comparable levels of blood pressure control in these two groups, okay? And then looking here in the lisinopril group, the lisinopril alone people had to have a step up in their medications and had more second line medications added to achieve the blood pressure control. But looking at the urinary aldosterone excretion, that was similar in both groups. And the urinary albumin excretion was similar in both groups. No statistically significant difference between those two. So the monotherapy with the ACE inhibitor was sufficient to achieve blood pressure control, and the addition of the ARB did not confer an additional benefit. And both groups had similar reductions in those, and the adverse events and common symptoms were similar in those two groups. Okay, so no benefit to ACE and ARB together. Okay, another drug that we talked about earlier is somatostatin, and that acts on the SST2 receptor to inhibit CAMP accumulation in the kidney and the liver, and it is used in polycystic liver disease to decrease liver cyst size. And it halts expansion of hepatic cysts in the studies of rats. And then there was a pilot study that showed some benefit. And just very recently, in 2013, they had a randomized controlled trial of 79 patients on somatostatin, and it showed a 50% slower cyst growth in the kidney cyst in ADPKD in the somatostatin group compared to the placebo, but it was not statistically significant. But it's promising, and they are designing and are getting underway a larger randomized control trial to test that. Okay, mTOR inhibitors. We also looked at the mTOR pathway, that if you block the mTOR inhibitor, if you block the mTOR, you can decrease cell proliferation. That's the theory. So they had a study in 2010, randomized controlled trial, double-blind, 400 patients, with the primary outcome, once again, is the change in total kidney volume. Secondary is renal function, change in cyst, and parenchymal volume. And GFR, they had, this was fairly advanced kidney disease. GFR 30 to 89, and the baseline total kidney volume was pretty big. So this was advanced disease. They tried the mTOR inhibitor, everolimus. What they found that everolimus significantly slowed the increase in total kidney volume at 1 year, and then it had a trend toward controlling kidney volume at year 2, okay? But the benefit was attenuated a little bit in that second year. And the annual decrease in GFR was actually higher in the everolimus group compared to placebo. So their kidney function got worse on this medication, and they had increased proteinuria. So essentially, this showed that it benefited total kidney volume, but the GFR got worse. So you have a complete separation of total kidney volume from the GFR, and it really called into question using total kidney volume as a surrogate marker for kidney function, okay? So slowing the progression of kidney enlargement does not necessarily improve renal function, okay? And this was, you know, that's a significant thing to, you know, call into question your endpoint on so many of these studies. So there was another study published at the same time in the same magazine, the same issue of New England Journal, that looked at the mTOR inhibitor sirolimus. And 100 patients followed for 18 months, and these had less severe disease. The creatinine clearance was around 70, the ages were younger, and there was essentially no difference in total kidney volume or GFR between these two groups. And the sirolimus group had increased albuminuria. They had a lot of side effects. You get tremendous side effects with these. You have mucositis, diarrhea, peripheral edema, and the other study, I think they got some leukopenia. And so treatment with sirolimus for 18 months did not halt the PKD growth, okay? So then we are looking at vasopressin antagonists. And we looked at that on the slide at the beginning. So the vasopressin stimulates CAMP, and that causes proliferation and increased secretion. So thinking, you know, maybe by blocking that, you can block the rate of growth in the kidneys. So it worked pretty well in some studies of some rat and mouse models. A phase 2 clinical trial of tolvaptan, the V2 receptor inhibitor, was pretty well tolerated. And then also, let me just tell you that along these same lines, you know, how do you decrease vasopressin? Okay, one way that they, in separate studies that they talked about doing that, is just to drink a tremendous amount of water. If you drink a lot of water and keep your urine osmolality as about 250, that actually can decrease vasopressin, and along the same lines, physiologically, decrease the rate of cyst growth. So that is also along those same lines, and a lot of people recommend doing that. Okay, but looking at the vasopressin receptor antagonist, this is the TEMPO trial, came out in December 2012. Phase 3 multi-center, double-blind, placebo-controlled tolvaptan in 3 dose levels with a 3-year follow-up. Now these had younger people. Their kidneys weren't that big. Total kidney volume, it was above 750. GFR was fairly well preserved, GFR of 60. So they had 1,445 with a 2-to-1 ratio. They went for every one who went to placebo, 2 would go to tolvaptan. So the primary outcome was annual change in total kidney volume. Okay, the secondary outcome was composite time of clinical progression and change in kidney function measured by the reciprocal of serum creatinine. So the greatest effect on the total kidney volume was in 1 year. And you see that in the tolvaptan group, the increase in total kidney volume was 2.8, and placebo it was 5.5%. So you did get a response here with the tolvaptan. The composite endpoint was a series of events that would occur. In tolvaptan, you had 44 events per 100-person follow-up years, and 50 events in the placebo group. Now, the decline in renal function was less in the tolvaptan group. There was a slight advantage. It was statistically significant, but there was a correlation there with a decrease in the kidney volume and the GFR, okay? But the discontinuation rate was really high in the tolvaptan group. And looking at this, this is kind of showing you, this is the placebo and the tolvaptan. You can see this change in total kidney volume. The slope of this line is lower than the slope of this line. And then over here, in change in kidney function, the placebo group's kidney function changed a little bit more, but you can see how this is not a huge difference, but there is a statistically significant difference there, where the people on tolvaptan had a slower rate of decline in their GFR. And this is looking at, this is the composite endpoint. They looked at worsening hypertension, worsening albuminuria, pain, and kidney function. And this is showing you that the risk, this looking at, compared to tolvaptan, the risk of getting cumulative event hazard is 0.87, okay? Worsening kidney function, it's 0.39. The hazard ratio is 0.39 with tolvaptan. And clinically significant kidney pain, the hazard ratio is 0.64, okay? So there were the adverse events that you would associate with having autosomal dominant polycystic kidney disease were higher in the placebo group, okay? 5% of them discontinued. But the adverse drug reaction were actually increased in the tolvaptan group, and those were aquaresis related, hypernatremia, polyuria, and they had this kind of concerning elevation in the liver function test. They had the AST, ALT, and bilirubin increase. And but the lab abnormalities returned to normal once they stopped the drug, but they took them off the medication. Now, the FDA looked at these results and thought about it, and they did not approve tolvaptan for treatment of autosomal dominant polycystic kidney disease. And the reason is, one of their main reasons was they did not accept total kidney volume as a surrogate marker for renal function. So that they needed more than just total kidney volume to let them know that tolvaptan was effective in treating this ADPKD. And then there was only a very small benefit to tolvaptan with regard to the GFR. It was a very small, and that it looked like, similar to sirolimus, the biggest effect, the biggest benefit was in the first year, and it was less in the second year. So they didn't know if the benefit would persist long term, and the risk of this liver dysfunction outweighs this very small benefit in GFR. So they looked simply at the GFR. They didn't give this total kidney volume as much weight in making this decision. And now tolvaptan has a black box warning for liver dysfunction. So other treatment you can have is renal replacement therapy. Peritoneal dialysis is less preferable because they may have very large kidneys, and intra-abdominal space may not be available for them. And increased risk of peritonitis with cyst infections. Hemodialysis or peritoneal dialysis ADPKD patients do better than non-ADPKD hemo or peritoneal dialysis patients. They do better. They survive longer on dialysis than non-PKD patients without regard to modality. Also, renal transplant is an option. Usually the outcomes are good, and a few complications appear to be more frequent, like erythrocytosis and symptomatic aneurysms or UTIs, diverticulum. You can have a nephrectomy after the transplant, and that is to better accommodate the allograft. and to avoid recurrent UTIs in a person who's on immunosuppression, or to address chronic pain or hematuria. So I just will wind this up and let you know that we looked at the characteristics of the disease and the available treatment of the disease. And KT over V, when trying to validate these treatments and trying to understand what's the best treatment, the KT over V is a commonly used surrogate for progression of ADPKD, but its correlation with GFR is not completely clear. That's still being worked out, okay? And some of the least toxic ways to decrease the rate of cyst growth is blood pressure control with an ACE or an ARB. We saw that statins had an effect in pediatric patients. Increased water intake, 3 liters a day, can make a difference, and limit the caffeine intake, okay? Now the blood pressure goal, it's unclear what the goal should be. We saw in the HALT PKD study A that the goal of 110/70 had a benefit in terms of lower kidney volume over a period of time. So, but that was mainly a benefit in men with preserved renal function and larger kidneys. But could it work in women? I mean, maybe it could. So I think, for ADPKD, you can have either a 130/80 or a 110/70. I wouldn't recommend the 140/90 goal in these patients because there's too much benefit in terms of controlling hypertension and an association with decreased cyst volume and the benefits of that, and also decreased left ventricular mass index. So I would recommend a lower goal here. So the mTOR inhibitors and the vasopressin antagonists have significant drug reactions, and they're not available for treatment, but there is further work being done on those. Any questions?
Other than the mTOR inhibitors, is there other clear association between kidney volume and improvement in renal function?
Well, really the only one is the tolvaptan, but it wasn't a very good benefit.
The reason I ask is we use a lot of mTOR inhibitors in oncology, and we know one of the side effects we is a lot of decreased renal function. So I wonder if the two are unrelated. The reason you can't use it as a surrogate is that it may be decreasing volume and maybe improving kidney function on one arm, but on the other hand, it's increasing renal function by its effect on kidneys in other ways.
That was one of the big problems with these studies, with the mTOR inhibitors, because they do increase proteinuria and they can decrease renal function. So they were hoping they could have it at a dose that's tolerable for the patient, where it would the benefit of decreasing that cellular proliferation outweighed the negative effects on the kidney, and they weren't able to show it in these studies. But they were fairly short studies. The main one was 2 years, and the other one was 18 months. But there may be, and one thing they thought about, they mentioned, was that the mTOR complex is a series of like 5 different proteins. So maybe these two drugs work on one of those peripheral proteins that don't have the best effect in inhibiting mTOR, okay? So maybe if they find an mTOR inhibitor that works, is more effective and that can work at maybe a lower dose, maybe that would pan out in that way.
Very good presentation. Now we know that the GFR is directly related to your blood pressure. If your patient has a higher blood pressure, your GFRs are higher, so whenever we lower blood pressure, the GFR go down. So one thing that I don't think the authors commented on that paper for the whole PKD was that we had 2 arms. One of them where your systolic is about 100, another about 120, 130. So just by lowering the blood pressure, the GFR would have been expected to be lower in the lower blood pressure arm. We did see the benefit of lower kidney volume, which is, as you said, is a surrogate for better preservation of kidney function. So maybe that the lower blood pressure arm had lower GFRs because the blood pressures were low.
Could be.
And that could be one of the reasons why we did not see the benefit which could have been. So yeah, I agree with your point that I think at this point there is sufficient evidence right after the study, which was recently published, that lower the blood pressure in PKD patients. If it's tolerated, the lowest should be the goal for maintenance.
And you know, that's kind of a razor's edge, because we've seen in other studies that if you have a lower target and you bring that blood pressure down, you can actually push them further towards CKD and end-stage renal disease. So you have to select the patients very carefully to put them on that lower blood pressure goal. And another thing is, you know, if all these interventions and these people, these pediatric patients, they're showing some benefit in decreasing kidney volume, it's kind of astonishing to me that we don't screen, you know, when we could be, you know, we don't know if there's an ADPKD child out there with hypertension, and, you know, get them on a therapy to decrease the rate of increase, to decrease the rate that their cysts are growing. And that's kind of interesting to me. In January 2014, they had a kind of a consensus conference with the bigwigs on ADPKD, all the people whose names are on these studies. And they talked about, you know, what recommendations to make. And hopefully they'll come out, this is under the KDIGO group, hopefully they'll come out with a consensus statement that gives advice on how to screen. You know, should we go and find these people? If we have a parent with ADPKD, should we check their blood pressure? You know, should we be aggressive in going, finding their kids, check the blood pressure in their kid? I think it's a question. If you have these really non-toxic, easy to administer interventions that could be beneficial, you know, it would be easy to help them onto those treatments. Okay, well, thank y'all so much. I appreciate it.